up? This is Caroline with the CWC podcast, where we believe that life without your favorite foods is not worth living. I'm going to be talking a lot about my journey to food freedom, and of course, I will always keep it real by sharing the good, the bad, and of course, the ugly. We are back at the CWC podcast. I have a very special guest today, Dr. Kevin Brenner, who is a board-certified plastic surgeon, obviously specializing in explant surgeries, and he is here to basically talk about the importance of breast implant illness, the fact that it is real. He's also going to share his own experience as a plastic surgeon. I love getting this side of it. It is, it's very impactful for women to share their story. I always talk about that, but when we can get a plastic surgeon to talk about this, it is huge. And I'm so happy that he is going to be on today. He should be popping in any minute. So I'm going to go ahead and hang on, let me make sure okay. Okay. I'm going to do his intro before he pops in here. So, okay. Dr. Kevin Brenner is a board-certified plastic and reconstructive surgeon with over 15 years experience in private practice in Beverly Hills, California. A native of Los Angeles, Dr. Brenner received his Bachelor of Science degree from the University of Wisconsin in Madison, obtained board certification in general surgery following his first residency at Rush University, and then at Cook County Hospital, he completed a fellowship in tissue engineering and then obtained board certification in plastic surgery. Oh, he's here. Following his second residency in plastic surgery at UC Irvine. He has been in private practice and on staff at Cedars Sinai since 2006. So here he is with no further waiting. I'm going to admit him in and we'll get started. There we go. Can you hear me?
I can hear you.
Yay. Yep.
Is the audio okay? Because this is on my laptop.
Yeah.
But I can put it on my phone and use my earbuds.
No, it sounds fine.
Okay, perfect.
Yeah. How are you?
Good. How are you? Nice to meet you in person.
Doing good. It is nice to meet you.
Seeing you on Instagram, but that's
as far as it goes. Well, we'll get into some stuff today. And I just want to first say thank you for coming on here and sharing everything that you're going to share about breast implant illness, explant surgery, all of that stuff. So I just appreciate you doing this.
My pleasure. Thanks for having me.
Yeah, absolutely.
You're quite busy with your podcast, huh?
Very busy. Yeah.
Is this your full-time gig now?
Podcasting is not my full-time gig. Actually, I am a women's transformation coach. That is my full-time job. And then I just do live videos. I used to do live videos all the time for my girls. And one of my coaches was like, you just need to start a podcast because then you'll have basically a library of everything. And then it just kind of snowballed.
Got it.
Yeah.
All right, cool.
So I did your intro already, and I love what you said under, and I asked basically, what's a quick win that my listeners will get from our interview? And I love what you said. You said breast implant illness is real. It's affecting many women. And when someone develops it, they should be heard and treated appropriately. In my practice, almost all of my patients feel improvement in or resolutions of their symptoms when implants and capsules are removed. So I want to kind of talk a little bit about how important it is for women to just be heard when they come in and complain about symptoms or feeling sick, because I think that that's a lot of what is going on is they don't feel heard from plastic surgeons or doctors.
I completely agree with you. I mean, that's what I hear. I'm not in the office with them with anyone else, but I certainly hear from them, from many patients, that they feel like they have been, not only not heard, but in some cases demeaned and mocked or just told that they're crazy. Mm-hmm. And, for some people, some people hold physicians, in high regard and trust their opinion implicitly, which is good for some people and good for some physicians, but may not necessarily always be the case. I mean, we're only human. We make mistakes. Medicine is always changing and evolving. And I mean, it would be foolish for me as a physician to just kind of ignore what's going on. I mean, things change, and this is certainly a really good example of it. I don't have all the answers. I don't pretend to. I'm very, 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 very open, honest, and straightforward with patients in terms of, like, we don't really know what the root cause is. We don't really know. There's no lab test. There's no radiology exam that can say, hey, you have BII or you don't have BII, or you're susceptible or you're not susceptible. And that's the hardest part for me, for most of the patients, and for most of the physicians that I've kind of interacted with about this, including not only plastic surgeons, but other specialists, internal medicine, cardiology, endocrinology. I mean, the interesting, the important part about BII is that the symptoms are so diverse.
Right.
In just about every organ system. I mean, maybe there's a few exceptions, but just about every organ system, there's some symptom associated with, I don't know. I'm assuming it's some sort of inflammatory process that's affecting that organ system. I think it's an immune response that's just a non-specific immune response to having a foreign body. That's kind of my opinion on it. I mean, that's the only thing that to me makes rational medical sense that could be happening, is that, hey, there's this one thing that's serving as an inflammatory nidus, and it's like almost like your immune system goes haywire, and then like, well, why do some people get it and others don't?
Right.
Because I don't think it's a universal thing. I don't think it's accepted that 100% you're going to get it.
Correct.
And is kind of like why do some people who are exposed to COVID-19 lose their taste and sense of smell for a couple of days, and then they're absolutely fine?
Yeah.
And end up in the ICU on a ventilator and possibly die from it, because we're all different, and our immune systems are different, and our genetic makeup, even though it's generally the same, there's differences. That's what makes people unique.
Yeah.
But what I started seeing years ago is, one person who was told that they were crazy, and then you listen to their story, and you kind of listen to the progression of the symptoms, and then you see a second patient, and you're like, oh, that sounds kind of a little bit similar. It's not exactly the same, but it sounds a little bit similar to what this gal told me a couple weeks ago. And then one more, and then you start seeing this picture of patients. And I started saying to myself, there's no way that this is just coincidence.
No.
I mean, I understand that this was a patient-driven phenomenon. I understand this was not a physician-driven phenomenon.
No.
At all. And that in that, I mean, that there's a lot of potential bias. There's a lot of potential incorrect information. I mean, you can't believe everything that you hear and read on the internet.
Of course not.
And you have to kind of take a lot of it with a grain of salt. But when you see one after another, and the stories are just too similar to not pay attention to it. And these are not patients necessarily that have any secondary gain, right? I mean, I see patients from all walks of life with the same story and same complaints, and anyone from the person working at the grocery store to a nurse, doctors, lawyers, A-list celebrities, right? Who really not only have nothing to gain, but really don't want anyone to know about anything.
Right.
And the stories are very similar. And so like, and then you also have to think like, well, what woman in the right mind would want to take out their implants after they spent so much money, time, and effort putting them in, or correcting them, or swapping, whatever the case is.
Yeah.
I mean, it's a big decision to have that operation in the first place. And it's an even bigger decision to have the operation to remove them.
Yeah. And that's financially as well. It's not like, hey, I just want to go drop several $1,000s to have these taken out or to switch them. And I do agree with you that it is different for everybody. I know I still have friends who have them in. They're fine. They know that I'm very open about just my own experience with it. My symptoms didn't develop until I had mine in for 12 years. I was fine. I never had any weird anything until a couple of years ago. And it just, like you said, it was a snowball effect, and it literally attacked like every single part of my body. I had ear issues, throat issues, bladder issues, stomach issues, joint pain. It was like my entire body just haywire.
And so and because of that, right, as a physician, and it's easy to get upset with different physicians for not either understanding it or not believing in it, not accepting it. But you have to kind of get into their shoes and say, hey, well, you know what, I've had this X number of years of medical training. This is what I've learned. This is what I know. This is my experience. And, this story just doesn't make sense. Right. Yeah. And there are a lot of things in medicine where stories don't make sense, but this is a big one. Yeah. And so it's very easy to get upset at physicians, but you really kind of have to step back and look at it from their point of view. Like, well, like I'm not, our obligation is, no matter the specialty, is first do no harm. That's our Hippocratic oath. And so, you don't want to just take a patient's word for something and send them down a path that's going to put them, under anesthesia for a few hours, right, and have a potential complication, because it's real surgery. People can bleed from it. You can drop your lung during the process of removing it. There's scars. You can injure nerves, interfere with the ability to breastfeed. Like, these are all things that can and do happen. And so it's like, well, why, if I have you, let's say, in front of me, and I'm like, you look great, your implants seem fine, totally soft, we image them, there's nothing there, like, why would I then take that next leap and say, well, okay, well, you need to have surgery? It doesn't make sense, right? So, but I've seen enough patients where I'm like, okay, you need it. And then there are some patients where I'm like, they come in, need to get my implants out. I saw this on Facebook, and and I'm like, I really don't think you have it. I don't think you have it. And as a result, if I put you through this operation, there's a good chance that you're not going to have any change in your symptoms, because I don't think it's related. Right. Like, people get headaches, people get pancreatitis, people get chest pain from all different reasons. Right. And rashes and hair loss and all the things that are accompanied with, experience, and that other patients have experienced. Like, it just, it happens. So it's just a matter of saying, let's look at the constellation of symptoms. Let's listen to the story, and then, like, also make sure that there's nothing else going on that's also serious, because we don't want to ignore chest pain from a heart problem, right? That would be bad. Or shortness of breath from a lung disease, because there are lung diseases that happen, or thyroid diseases that happen in patients who've never had breast implants or any implant. So, so I think it's a slippery slope, and we got to be very cautious in terms of how you proceed with every patient, because it's very easy to say, well, if you had 100 patients who did better and clearly had BII. Well, maybe the next 1,000 patients that come in with any symptom, it's got to be BII, right?
Right.
It's very easy to kind of group it together and just say, chalk it all up to BII, when that's when you kind of get into dangerous territory.
Right. And that honestly, when I first started experiencing symptoms, they didn't all come on at once. It was a very slow kind of a trickle effect. So when I first had like my throat clearing issues, I just had kind of shoved it to the side and I was like, I don't know what it is. My doctor didn't know what it was. And then the exhaustion came on and, that was, well, I've got 2 kids. I work full time. We have a ranch. Like I'm tired. Like my husband's tired every day. So sweep that one away. And it was just, I kept kind of putting him to the side. And I did, my doctor, she's very open-minded and she kept trying to help me figure out what each thing was. And she just time after time, she was like, I don't know, like I don't know that they're related. It's just a bunch of weird things. And it got to a point where it was so bad that I almost just knew, and I just knew my own body. And I've never been that sick. Like I've always been super healthy. So I knew something was definitely wrong. And when I got mine out and all the symptoms pretty much resolved fairly quickly, I just, talked about it and speaking to other women with, like you said, when you start hearing the stories over and over and over and over again, it is really difficult to dismiss it. You can't just be like, well,
it is. I mean, it's still being dismissed, but it is. It's just, not by me, but
right.
There are plenty of people, societies, organizations who maybe don't want to believe that there's an issue.
Right. And that is understandable. I do know that doctors go through training and they go through school and they're taught everything. And this is fairly new. And to hear it, I mean, if I was a doctor, I would absolutely be like, I don't know. And like you said, I don't want to put you in harm's way by telling you to go have an unnecessary surgery if I'm not 100% sure this is what it's from. So,
and it's hard to be 100% sure for any patient. It really is. Sure. I mean, there are some who are clearly suffering more than others.
Yes.
But then like I see them on Instagram, a week, 2 weeks, 3 weeks after surgery, and they're just changed people. I mean, I see patients back the next day very often, not across the board, but very often they just feel like a weight's been lifted off their shoulders.
Yeah.
There's definitely a physical component to getting the implants and capsules out, especially when they're below the muscle, because that is constricting.
Yeah.
There's a study that shows that removing everything increases the lung capacity a little bit. So that's like tangible, demonstrable data that we can use to say, hey, there is some benefit to this. And 2 years ago, when I was talking about this, maybe 3 years ago, like I would say, this is what I think it is. There's really no data to support it, but those studies are starting to happen. Mm-hmm. And I see a little bit of a tide change in our societies. Last, I think it was ours, or genuinely don't believe that it's true, right? Mm-hmm. But yeah, in our meeting, there was a couple panels about almost like a debate, like, is it real? Is it not real? But the fact that that's happening, whereas a year or 2 years ago that didn't, or 2-3 years ago that wasn't happening at all. I mean, I recall going to, I'm in the LA area and my practice is in Beverly Hills, and I went to one of our meetings, our ground rounds meetings about breast implant illness, and I was kind of talking to a room full of mostly plastic surgeons, and just got kind of relating what my experience had been. And I asked the question, raise your hand if you believe that BII is real, and I think maybe 1 person out of 50 raised their hand.
Wow. And
this is a group of very busy plastic surgeons in Southern California, in LA, in Beverly Hills. So
wow.
So yeah, that's still an issue, and I think that there's probably a fair number of people who look at me just for talking about it and think that I'm crazy, but I don't think so.
No.
I really think there's something, and this is about, we started collecting data because I want to know. I mean, I have enough patients where I'm like, I need to know, like, which patients are getting better, how many of them, how much better are they getting, especially because it's all subjective, right?
Right.
For the 99% of it is subjective.
Mm-hmm.
I mean, there are maybe not quite that high, but there are outliers. I mean, I can remember last year I explanted a gal who, I mean, she was very bad, and this is someone who is a high-powered executive, right? So she had, like, this was not about money. This was not about secondary gain. She legitimately had a problem. And she went back to her original plastic surgeon, who outright dismissed it. And it happens to be a surgeon who continues to be very vocally against the idea of breast implants. And so she finally was like, screw it. Like, if he's not going to do it, I'm going to find someone who can help me. And I explanted her, and she had, not normal. The capsules were not normal. They were thickened and inflamed and calcified and stuff. But she had an old hematoma inside one of the capsules. It had, a big one, not a tiny little bit of blood, a big one that had been there. I mean, this is probably 8-10 years after her original operation. And so, that's when I say to patients, follow your instinct, because if you really think that there's a problem, then you shouldn't just kind of give up outright because one person tells you there's not a problem.
Right.
And so, I mean, I see that time and time again. I had another patient who, and I don't know if it's absolutely causative or related, but it certainly temporally made sense. She had suffered from pancreatitis, like inflammation of the pancreas, for years, in and out of the emergency room with abdominal pain. And in fact, and she had other symptoms, but like this was like her big thing. And we actually had to delay her surgery for a couple months because right when she was supposed to come in for surgery, she had a flare up, right? So I had to send her back to her pancreas specialist and say, hey, let's get this to calm down. We did it. And we did her surgery, and I think maybe a month out from surgery, 6 weeks out from surgery, her markers, pancreas markers, which we all have, right, back down to normal. Off of medications, back down to normal for the first time in 6 years. So, wow. I mean, it could it be coincidental? I suppose, but
that's a pretty big coincidence.
but there's a lot of coincidences, that could be coincidences that I don't think of.
No, I agree. So I'm going to ask you, let's see, what are the surgical treatment options for women with breast implant illness? And then what are some of the post-surgical treatment options?
So right now, in terms of our understanding of this, at a bare minimum, patients who I think they have, and I think they have BII, the current, I don't know if it's the accepted treatment, but the current accepted treatment amongst surgeons who are taking care of these patients is to remove the implants and remove the capsule, which is not a small undertaking. No. Oftentimes the capsules, unlike patients who have like capsular contracture where the capsule is a little thickened, patients with BII can have completely normal, thin, pliable capsules. I often tell patients that often the capsule can be so thin that it's often like the fibrous lining on a hard-boiled egg that you can see through. Wow. It. Yeah, I mean sometimes they're that thin. So and it takes some time, and most patients, the implants are below their pectoralis muscle, so you got to peel it off of that. I got to peel it off the rib cage. It hurts obviously more. You can bleed from that. It's not a completely benign process, but it can be done safely in the right hand. And in fact, I'm involved in an article that we're currently writing with some other surgeons at one of the local universities, where we're showing that it can be done safely, and there's no, the complication rate is really not appreciable. So
love that.
So I lost track of where we were, but so that's kind of the bare minimum in terms of like what needs to be done.
Yes.
In terms of treating the BII, then there is the next step, which is how can we make the breast look as aesthetically pleasing as possible? Mm-hmm. And my practice, my background was in general surgery before plastic surgery. I have extensive experience with all types of breast surgery. And just since I've been in practice, even though I kind of do everything, I'm not just an explant surgeon. I do facelifts and liposuction and all different types of tummy tucks and all different types of breast reductions, and for many years it was really had a big patient base of revision breast implant cases, right? Managing complications from things like that. So that was so I've been doing this type of surgery for a long time, even before it was for BII. Yeah. And so there are options, and sometimes we take out the implants and capsules and do nothing else, and the results are fine. And other times, the patients have such a little breast tissue that there's not really much to work with. Most of the time, I would say most women, because the effect of putting an implant in somebody, not for everybody, but for most of the time, it's not just the fact that the implant is there. The implant, especially when it's below the muscle, over time changes the chest wall, changes the quality of the breast tissue. And so, you have a 300, 400 cc breast implant sitting on the chest wall, and you have the muscle. Every time you go to do a push-up, every time you activate your pectoralis muscle, it's pushing pressure slowly against your chest wall. Well, the chest wall is a living, breathing thing, and it's going to respond to pressure. And oftentimes the chest wall can get a little bit scalloped, so that the space where the implant is now bigger than it was the day that it was put in. Interesting. So when you take it out, you're not going back to square one. You're going back to like square -1, right? Yeah. So there's that. And then just the weight, especially with a heavier implant, the weight of the implant oftentimes stretches out the skin and the breast parenchyma. Mm-hmm. And so the quality of the tissue is not quite the same. Many times patients had implants put in when they were younger, right? And now they're 10, 15 years older, and they've gotten married and have had 1 or 2 or 3 kids and breastfed, and all those things change the quality of the breast tissue. And, a lot of times patients come in, even with their breast implants in, I look at them and I'm like, you need a breast lift, even if you were to keep your breast implants. Right. Them out, you're definitely going to need one. And then, the women who have a decent amount of breast tissue are the ones who are going to usually get the best results, right? Because I do a breast lift and I'm like, it's a beautiful, naturally looking breast. And some people are smaller and we need a breast lift, and we do fat transfer. Mm-hmm. We'll do liposuction from another part of the body, and then graft it into the breast tissue at some point. And I've gotten some nice results. You're unlikely to see the same volume that you would see with an implant, right? Because what a lot of people who aren't surgeons don't necessarily understand is that a breast implant, you put it in, it's one solid implant. You put it in, the implant doesn't require blood supply. Your body grows a capsule around it, and the capsule has blood supply, but the implant itself doesn't have blood supply. But you can't just take out that implant and then replace it with a bunch of fat and expect that that's going to live, right? The fat needs to live off of your body growing new blood supply into it.
Right.
So if you take out a 400 cc implant, maybe I can put 100 cc of fat into each side, and hopefully most of it will stay. It doesn't all stay. Sometimes we need to do it more than once, but there are options, and except for patients who are so skinny that they don't have any fat, then that becomes a problem.
Yeah. I for sure had to have a lift. He was like, you don't have hardly any breast tissue, which I knew was going to be the case. And so he was like, my surgeon said, yeah, you for sure need a lift. But I mean, I was very happy with my results. I wasn't too I actually like my scars. I know a lot of women are hesitant to get the surgery because they don't want the anchor scars, but I actually I like my scars now because I feel better.
You own them. Sorry.
Yeah. I absolutely own them. Okay. So my next question is, what is the Brenner Breast Team and why is it unique?
That's a good question. So this has been a work in evolution, taking care of BII patients. I am a Western trained physician, right? I went to medical school in Chicago. I did my residency in Chicago. I did my second one at UC Irvine. And that's my vantage point. That's my basis of operations. That's what I know. And that's my education. And that's not going to change. I can't change what has happened.
Right.
And that's my wheelhouse. I mean, that's my expertise. My expertise is knowing how to take care of people surgically, medically, and doing a good job in the operating room. And that's why I'm a plastic surgeon. That's what I do. So I don't pretend to know anything about alternative medicine. I don't pretend to know anything about psychotherapy. I don't pretend to know anything about medical implementation. I mean, I know a little bit, but not enough to guide someone, through the process.
Right.
And so I was years ago took care of a patient, Amanda, and got her through the process. And in her recovery, she was relating to me all the various different modalities that she had been doing leading up to surgery and then after surgery. And all the, holistic practitioners that she had been seeing and who had been treating her, who were helping her with this, that, and the other. And I said, that's amazing. And at one point, when I saw her back, I mean, she was doing great. And at one point I saw her back and we were having this conversation, and at some point decided to team up. I was like, this is what I do. I know I can do the surgery, but I can't do this other part. You know everything about it. You've been through it. You know the practitioners. Why don't we kind of join forces to say, hey, I do this part and you do that part. And so Amanda helped put together a team of people who take care of various problems related to breast surgery. I mean, it's not all related to breast surgery per se, but it's all related to the healing process from surgery.
I love that.
So it's definitely very helpful to me, because not only do I not know how to do it, but I don't have the time to do it.
Yeah.
So I get patients through their initial recovery, hand it over to Amanda or to Sarah or to Leah or to Ruth, one of the Jasmines. We got a Nikki, and it's all on my website in terms of like who does what. But we have holistic practitioners and naturopaths and therapists and specialists in micropigmentation for scar camouflage, for women who've had breast cancer and had mastectomy, for nipple areolar reconstruction with tattoo, and so like the detoxification.
Yeah.
some patients have been doing ozone therapy. And I truthfully don't know what is going to work for any particular person.
Yeah.
And nor do I have the time to figure that out. Right. So working with them makes it so much easier for the patient. And it's just kind of like a one-stop shop. And even though we don't operate out of the same office, and none of us are in the same office, but we all communicate with each other. And, nowadays, especially now,
yeah,
post-COVID Zoom protocol, like, it doesn't really, there's so much that you can do without being in person.
Yes.
That it doesn't really,
doesn't matter. You wouldn't have to be in the same spot.
No. Yeah. So, and to my knowledge, not only do we have the first breast team, kind of like, I'm not talking about like breast, there's plenty of breast cancer, university breast cancer teams and stuff. I'm not talking about that. This is just my first sort of cosmetic or paracosmetic breast team in the country that I'm aware of. I know it's definitely the first one in the LA area. I think
I've never heard of it. And I actually really applaud you for bringing it together like that, because a lot of doctors, a lot of them that I know personally, don't really necessarily believe in functional medicine doctors or holistic practitioners. They just don't. It's like, this is what we do. That's what they do. I don't know enough about it. You know what I mean?
Well, neither do I, but I have always said, even before I was in plastic surgery, I've always said, I'm not opposed to holistic medicine. I'm not opposed to osteopathic medicine. Whatever works.
Right.
There's definitely, I've always said, so for some patients, acupuncture works.
Yeah.
And if it works to get you to quit smoking or to get rid of your chronic neck pain or whatever the situation, if it works, it works.
Yeah.
It doesn't work for everybody. And if it doesn't work for you, okay, then we'll try something else. But there are, I've never been a naysayer about it. I certainly, as Western physicians, we don't know everything. There's been a lot of great advances in medicine and surgery, but we don't know everything. And not everyone responds the same way. So
correct.
Like everyone needs to do the same protocol. I just think that's kind of foolish.
Yeah.
And it's not, and I may have, I have patients who don't see anyone on the breast team other than
right.
And they're fine. And that's okay.
Yeah. And you probably have quite a few that utilize that whole side of it. And it's probably really helpful. So I just think that's awesome. Awesome. And I think you kind of answered this earlier, but I want to ask if you're involved in any research or investigations to study BII. You touched on this a little bit.
Well, so I kind of, there are a handful of explant surgeons around the country who've been working on this. There's some good data coming from outside of the country, actually.
Oh, wow.
In particular, Australia. Australia and New Zealand have big numbers when it comes to breast augmentation, especially with silicone and textured silicone implants. The whole ALCL phenomena first kind of picked up down in, I think it was either Australia or New Zealand. So I said, first of all, I said, there's a paucity of information. And even though I'm in private practice, I'm not doing, big university studies. I don't have the time for it, nor myself. Yeah. But I am, number one, collecting data on my patients just in terms of like, what symptoms are they having before surgery? What symptoms are they having at a week, at a month, 3 months, 6 months, a year? And what's the severity of those symptoms?
Right.
Did they go from a 10 to a 2? Did they go from a 4 to a 3? Because I want to know like what's significant. I want to know what the most common presenting symptoms are. I want to know what percentage of patients are getting better and to what degree. And so that's, I don't know. if it's going to be the best paper or if it even is going to end up into a manuscript, but at least it'll give me information in terms of what to go off of. And then I'm working with a major university in LA on some other things. We have some other studies, and I think, they have their staff who are involved with it. I think I'm the only private practitioner in LA currently involved in these studies and writing manuscripts and stuff. So it's good. It gets me back to my residency days when I was publishing a lot.
That's awesome. I mean, the fact that you're at least collecting that data and kind of watching it and monitoring it. And like you said, seeing what was the severity of the symptom before you explanted, and then what is it after? I mean, you can't ignore data. I say that all the time. And so you're seeing it over and over. Well, you can, you're right.
You ignore it all the time. But what it does is it gives me and us some validity to what we're doing. That we're not just doing it to do it. We're not just operating on patients to operate, which, by the way, if someone wants their breast implants out, even if they don't have BAI, they should have the right to request it.
Right.
As long as it can be done safely. I don't I have a lot of patients that I explant who don't have BAI.
Yeah.
They have their implants put in, they have a couple kids, the breasts actually get bigger, and they end up being bigger than they were before they ever had their implants put in, and now they're too big.
Yeah.
And so they're like, I just need them out. So why if they can request them in, they should be able to request them out. I just don't see why that's.
I agree with you on that. And I wasn't fully aware that my symptoms were all related to breast implant illness. After I made the decision to explant, I went in to get a consultation about taking them out literally off of a gut feeling. And I sat down with my surgeon and he said, well, what symptoms are you having? And I was like, symptoms? I was like, I just want them out. Like, can't you just take them out? And he was like, well, I can, but I just want to make sure, like, basically he was trying to say, like, what reason are you wanting them? And I was like, I just want them out. And then as soon as I made a post about it, deciding to do it, that was when I kind of came to the conclusion, because hundreds of women just started messaging me and they were like, well, I'm having this symptom. Why are you choosing to get yours out? I saw my friend do it and she felt better. And then it just kind of, I was like, oh my gosh, this could absolutely be related to what I'm going through. And it ended up being that, obviously, but
right.
Yeah.
I'm seeing, I'm not pretending to know what it's like to be a patient, BII patient, but I'm seeing with it, with every interview, with every podcast, with every news piece, with every article, the response, because now it's like, nowadays the response is almost in real time, right? You put something out there and within, hours, start getting people chiming in. Mm-hmm. And the response is real again, still a lot of naysayers out there, but I think that us talking about this, anytime you can kind of amplify the message and get it to the more people that know about it, the more you're going to have patients go, oh, well, shit, I've been suffering like this for 3 years. I didn't even think to connect the dots, that maybe that's what it is.
That's exactly, I can't tell you how many women have messaged me and they're like, I didn't even think about that. it never even crossed my mind. And then I have girls who are like, I was wanting implants. And now after hearing like what you went through, like, I don't know that I want them. Like, I don't know that it's worth it,
And that's fine. I mean, they're entitled for that decision. And that's the other thing that not just myself, but in particular, some of the other advocates that I interact with, I don't work with necessarily, but interact with, are focusing on legislation in various states in terms of improving the informed consent process. I've always said, I learned this early. I learned this when I was in medical school, when I was an intern. Informed consent is not about having a patient sign a document. It's about having a conversation with them so that they understand what they're signing up for.
Right.
And what the benefits and the risks and potential complications are. And until, I mean, that you could very easily turn that into a 5-hour tedious conversation, or you can kind of just hit the bullet points and let them read through the consent forms. But the point is that we shouldn't just be burying things in page 24 of 40 of consent forms. Unfortunately, consent forms are a necessary evil. It's just what it is. And it's great for the court system, but it's not great for the patient necessarily. They need to understand it, not just see it in black and white.
I agree.
And they need an opportunity to ask questions like, well, is this going to happen? Can this happen? What's the risk? What's the percentage? And if you're signing up for anything, you should know that.
Yeah. And I teeter back and forth between, I know that it is still very new. When I got my implants in, that was 13 years ago. So I go back and I'm like, because I say all the time, I'm like, if I had known that this would have happened to me, I never would have gotten them put in. However, I don't know that most surgeons even knew about all these random symptoms that could happen.
Well, and we didn't.
Yeah.
In defense of the deniers, we didn't know.
Right.
And you could even argue that we still don't really necessarily know. Not yet. I mean, we're working on it.
Yeah.
But it's a process, and it takes time. I mean, research takes time. Research takes years.
Years. Yeah.
Even when you're not like doing lab work, it just takes time.
Yeah.
And I could say, well, I'm standing hard and fast, and I'm not taking care of one of these patients until I have some really good published data that it's beneficial.
Yeah.
You could take that approach, and some people probably are.
Mm-hmm.
And there's nothing wrong with that necessarily. It's just certainly a safe way to go. But at the same time, it's really hard to see women come in your office, often miserable, suffering, tearful, with no other reason for being ill, and say, well, I got to wait for a couple of years until we get some data, and so that they leave my office and then go somewhere else, and who knows what will happen, right? So,
right.
Like, I know that this is what I do. I'm an expert at breast surgery, and I know that I'll do a good job and take care of them, and complications happen to everybody.
Right.
The only surgeons that don't get complications are the ones that don't operate. That's what I learned.
Exactly.
Day one of internship. So, but I'm willing to take that chance because I've seen so many. Like,
you've seen it, and you're, I don't want to say sure, but you've seen it happen with women, and then they explant, and then they feel significantly better. So to have someone sitting in front of you crying and they feel miserable, and a lot of these women are moms, and I can speak for myself too and say that I had a lot of mental issues that was associated with my BII, and it was so hard some days as a mother, just trying to like not only just make it through the day, but like be there for your kids and shut off everything that's going on. It's hard.
It's hard to be a mom, even when you're firing on all cylinders. It's a challenge. Being parents is probably the most challenging job that any of us have. But
yes,
my wife does the lion's share, but for what I contribute, it's not so easy. So
no.
I think we're doing the right thing.
Yeah, I absolutely know that you're doing the right thing. And I just like how open you are, open to other possibilities. And like you said, medicine is always changing, and things that we didn't know 20 years ago, now we know today. And
I mean, look, I literally just read over the weekend, right? If you had asked me 6 months ago what's the word on the street about taking aspirin as a prevention for heart attacks? Aspirin, one of the oldest medications that we have, right? It's just sort of like almost like knee-jerk default reaction. Like, yeah, after a certain age, take an aspirin, it lowers your risk of developing a heart attack. Period. It was accepted as dogma, right? Just last week, there was a study that said, no, it's good up until, if you had a heart attack, it's useful. If you haven't had a heart attack in the past, it's not so. And then, that's different if you're age 60 and above versus if you're age 59 and below. So they completely revamped what had dogma for years. So, I mean, if that kind of change would happen like on a dime, like why can't this be a thing?
Yeah.
And this is certainly, I would argue, it may not be as common as cardiac disease, but it's certainly more complicated sometimes, right?
Yes, absolutely.
Do it, and I mean, it certainly can be. And you talked about being a parent and just being run down and not being able to do what you can do and not being available for your family. I have, there's a lot of patients that I see who kind of have been jumped into this on their own, right? And I invariably, when I'm meeting with the patient for the first time, I always kind of ask, like, what's your husband's take on this, or your spouse, or your partner, or whoever? And a lot of times they haven't even had a conversation with their spouse about it, which is always a little bit of concern.
Mm-hmm.
But I also have the other extreme where, I mean, I can think of 3 patients in the last year who came in, and one of them in particular came in with her husband for her consultation, which is great, right? And the patient herself was almost not quite, but almost catatonic, right? She just was not interacting, not smiling, not just one-word answers, and her husband had been her complete advocate, like amazing. He's like, we went through every specialist in the Kaiser system. We saw internal medicine, we saw rheumatology, we saw urology, we saw 15 specialists. No one could figure out what was going on. And this was over like 2 to 3 years. He's like, finally we changed our insurance and went and got private insurance with one of the Blues or something. And the same thing. So they went through it twice with zero answer. And to the point where like their life had become going to doctor appointments.
Yep.
To try to figure out what it is. And she was completely unavailable for her kids. And he was taxed to the point where it was hard for him to even be available for the kids.
Right.
And a month after surgery, she's a different person.
Wow.
And it's just, so it's hard for me. It's really hard for me. I mean, I don't care how many naysayers there are. It's hard for me to ignore cases like that.
For sure. I mean, that's a really powerful story. And that is very much what it feels like. I spent 1.5 years in and out of specialists and no answers. And you kind of do become, I say this, I said, I felt like such a shell of a person for so long because you just get burnt out. You're like, I've spent so much money. I've spent so much time and I still don't know what's wrong with me. And so when you do finally come around to thinking, okay, I might have an answer for this, and then you do it and feel better, I feel like I was like born again. I felt like I got my energy back. I don't have to come home and take a nap after working 5 or 6 hours. Like I can be there for my kids. And it's
why should a 24-year-old who was previously healthy, bedridden, and for no apparent reason,
right?
Especially when they are professionals and have a job, and
and there isn't a conclusive answer or a medical diagnosis. That's where it's like, okay, if you've been to this many doctors and they don't have something that is officially wrong with you, then yeah, it's got to be something else.
So anyway, that's why we're doing this.
I just appreciate it so much. Before we go, I ask all of my guests, I'm a huge Freddie Mercury fan, so I have to know what your favorite Queen song.
Too.
Oh, yes.
My favorite Queen song. Oh, wow. My knee jerk would be Bohemian Rhapsody, but that's not my favorite song. I would say Who Wants to Live Forever.
Oh, I love that song. No one has answered that yet either.
I think it's every time I get chills every time I hear him sing that song.
Yeah, I do too. I love that.
It's a very like dark, sad song. Right?
It is a dark song.
It kind of goes, but it's such a beautiful song.
It is. And he, obviously put so much energy and life into all of his songs. So it's hard to listen to them and not get goosebumps, but I love that you answered that well.
What do you do if you get through an interview with someone and they don't know who Queen is or they don't know any of their songs? You just like erase the entire thing. It's like, sorry, okay, you're done.
This happened last interview. It hasn't aired yet. And this was with like a big named person and it's coming out. Oh my gosh, it's airing this Friday. And I asked her, I said, what's your favorite Queen song? And she was like, I don't remember if she said she didn't know who Queen was, but she was like, I'm not really like, I think she did say she didn't know. And I was like, how do you not know who they are?
It's crazy, right?
Yeah. She was like, well, I just primarily listen to like 90s R&B and stuff, which it was totally fine. But I had to kind of school her a little bit on some Freddie songs.
My kids know Queen songs and they're 10 and 12. So
mm-hmm. Yeah.
I listen to a lot of rock music. Raising
them right. I like that. Well, this was so great.
They call me Shazam.
Do they? That is hilarious. Oh my gosh. Well, thank you again for doing this. It was awesome. I'll let you know when it's going to air and I'll put all of your links and stuff in the show notes and then we'll get it going.
Terrific.
Yeah.
All right, cool. Thanks so much. I appreciate it. Have a great day.
Yeah, you too.
Keep on keeping on.
Same to you.
I'll see you on Instagram.
On Instagram. I know. I was about to say that. All right.
Bye-bye.
Bye. Thank you for checking out the CWC podcast. If you want to learn more about our community, make sure to check out the show notes.